Welcome to the Radiographics Podcast, brought to you by RSNA. I'm Wendy Gibbs. This week, since everyone is still recovering from all the great learning at RSNA, I'm sharing something fun. I want to highlight the relatively new feature started by our editor-in-chief, Cases from the Cooky Jar. These are educational cases with outstanding imaging, kind of like our regular papers, but shorter. I encourage everyone to look at these online or on Twitter. Let's start with anti-NMDA receptor encephalitis. This is a rare condition characterized by the presence of autoantibodies against the NR1 and NR2 subunits of the NMDA receptor. Patients typically present with psychiatric symptoms, anxiety, hallucinations, psychosis, and may experience progression to sleep disorders, seizures, dyskinesias, and autonomic instability. The imaging features of this can vary, but usually include brain volume loss, usually involving the temporal lobes. Asymmetric temporal lobe or cerebellar cortical hyperintensity on FLAIR images can also be a feature of the disease and may be accompanied by restricted diffusion. In their first imaging figure, the authors show brain MRI findings in a 14-year-old girl. Her symptoms were initially headaches, followed by visual and auditory hallucinations, dystonia, akaesthesia and facial dyskinesia, insomnia, hygiene neglect, aggression, and expressive aphasia. Wow. This later progressed to loss of consciousness and central hypoventilation. The FLAIR image obtained 4 days after the onset of symptoms shows scattered small foci of subcortical hyperintensity in the frontal and parietal lobes. There's no associated mass effect. There's no enhancement or diffusion restriction, and brain volume is normal at this point. Images obtained 2 months later show an increase in the size of a few of the T2 hyperintense lesions, along with mild generalized supratentorial volume loss. There was still no enhancement or restricted diffusion. Anti-NMDA receptor encephalitis is a paraneoplastic manifestation of tumors expressing the same receptors, NR1 and NR2. This is most often ovarian teratomas, which may contain mature and immature neurons expressing subunits of the NMDA receptor. Diagnosis is based on a combination of imaging and lab findings, which include serum and CSF autoantibodies, CSF pleocytosis, and/or high CSF protein concentration. Immunosuppressive therapy, like steroids and intravenous immunoglobulins, and tumor resection, if a tumor is present, most often leads to complete remission. The authors show ultrasound and CT images showing right and left adnexal masses, which have internal fat, soft tissue, and calcifications. On resection, these were confirmed mature teratomas. The patient underwent immunosuppressive therapy with methylprednisolone for 5 days and intravenous immunoglobulin weekly for 4 weeks. She showed improvement of symptoms and was discharged home. She has stayed symptom-free to date. I'm not sure how long ago that was, but we'll hope for the best. In summary, teratomas are rare germ cell tumors that may contain several types of tissue like hair, muscle, and teeth. Neural tissue in a teratoma can trigger the immune system to make antibodies against NMDA receptors. These attack NMDA receptors in the brain, causing encephalitis with psychiatric, neurologic, and autonomic symptoms. Immunosuppressive therapy and tumor resection are typically curative. All right, let's go to the next one from last month. Pulmonary light chain deposition disease. This is a multisystem disorder characterized by overproduction of non-amyloid immunoglobulin light chains that can deposit in any organ. Renal involvement almost always occurs because free light chains are predominantly filtered by the kidneys. Less common manifestations involve the liver, heart, and lungs. The underlying cause of light chain deposition disease is unknown, but it's often associated with myeloma or other lymphoplasmacytic disorders. About 50 cases of pulmonary LCDD have been reported since 1987. Characteristic imaging features include thin-walled cystic lesions with vessels inside or traversing the wall, and pulmonary nodules that occasionally calcify. These findings, particularly in patients with lymphoproliferative disorders, should raise suspicion for pulmonary LCDD. Diagnosis requires a biopsy, which shows nodular aggregates of amorphous eosinophilic material with plasmacytic and giant cell reaction. Deposits are not stained by Congo red, a finding that differentiates LCDD from pulmonary amyloidosis. The authors don't discuss further testing or treatment, so I looked it up. Blood or urine tests to detect M protein are strongly recommended once the pathological diagnosis is confirmed, to help eliminate the possibility of other tumors of the hematological system. The removal of the abnormal plasma cell clone and the reduction of the synthesis and secretion of light chains are the ultimate goals of LCDD therapy. Due to the rarity of the disease and regular involvement of multiple organs, no unified treatment exists. At present, the treatment regimen is mostly based on the comorbidities, such as multiple myeloma or Sjogren's syndrome or lymphoma, and complications, as well as involvement of extrapulmonary organs. So in the case of pulmonary LCDD, lung transplant may be considered. The authors show a case of LCDD in a 69-year-old man with multiple myeloma. Chest CT images show numerous thin-walled pulmonary cysts with vessels coursing along several of the cyst walls. It also shows an enhancing soft tissue mass occupying the right side vertebral body at T4 and patchy lytic disease throughout the thoracolumbar spine. T2-weighted MR images of the thoracic spine show epidural extension of disease, causing severe cord compression. Percutaneous biopsy of the T4 soft tissue mass was performed. The high-power photomicrograph, hematoxylin stain, used for histologic correlation, shows diffuse sheets of plasma cells. Kidney biopsy was also performed, as the patient also had nephropathy, and the results confirmed LCDD. In summary, monoclonal expansion of a malignant plasma cell overproduces free immunoglobulin light chains, a component of antibodies. These can affect any organ. In the lungs, these deposit in the walls of the alveoli, small airways, and vessels. All right, that's it for this week's podcast. Check out these cases and more in the journal and on Twitter. We'll be back in 2 weeks with more summaries.